This might be your superpower. Can you look at a woman and tell whether or not they've had breast augmentation?
No, not always. I mean, sometimes you can tell, but not
95%?
always. It's not like, well, I haven't tested myself. I don't work at a carnival doing this, so I don't know. But often, it's basically the woman's frame versus breast size. So you can tell when a woman has a generally thin frame and has breasts that are probably proportionately larger.
Before we dive in, it's important to remember that the information we provide is for informational purposes only. Every situation is unique, and decisions regarding your health or legal matters should be made after consulting with your own doctor or lawyer. Our aim is to inform and empower, but personal circumstances require personalized advice. We'd like to take a moment to thank our sponsor, findagreatattorney.com. If you or a loved one has been injured in an accident, finding the right lawyer can make all the difference in getting the compensation and support you deserve. Hi, welcome to another edition of Justice in Scrubs. I'm attorney Richard Hastings, and I'm joined by my co-host,
Dr. Jeff Michaelis.
Hi.
Hi, how are you?
We have a fascinating, and I mean fascinating, guest today with us, Dr. Sohail Islam, who is a plastic surgeon. Welcome to the program.
Thanks for having me.
Why don't we start off by what your journey looked like to get you to where you are right now?
Okay, so my journey is a little bit circuitous. I didn't always know I wanted to be a plastic surgeon. When I went to medical school, I originally wanted to be a pediatrician, and just for no particular reason other than I like children. But then when I was in medical school, I realized I like working with my hands, so I wanted to do some surgery. And I originally applied for ENT residency, which I got. But then during my first couple of years of residency, I didn't really enjoy it as much as I thought it would. And so I ended up doing general surgery and completing that. And then my best friend at the time was going to do plastic surgery. And I got more intrigued by that. And I eventually applied to plastic surgery and did a plastic surgery residency for 2 years down in Virginia. And then I subsequently did a year of a hand fellowship as well at Yale. After that, my wife was kind of fed up with traveling and having me just train forever. And she said, yeah, you got to get a job. So then I got a real job.
So do plastic surgeons have a specialty, or can you work on the whole body?
So one of the nice things about plastic surgery is you can work on the whole body if you choose to. Some people do choose to subspecialize because for a variety of reasons. And some people just do faces, some people do breast reconstruction, some people do hands, some people just do facial plastic surgery. It has a lot of different paths that you can take to wherever you want to end up, and hopefully you're happy where you end up.
So do you specialize?
I do not. I do, certainly in my group, I do more hand surgery than other people, but I still do a lot of cosmetic surgery. I do a lot of skin cancer, and just a lot of variety of things in plastic surgery. One of the nice things about the area I'm in is I've been around for a long time. I think I have a decent reputation. So if people come to me with something I can take care of, I generally take care of it. I don't usually send it out to have somebody else do it. If I feel comfortable doing it, I take care of it.
And are most of the hand surgeries the result of accidents or dog bites?
No, there's some accidents. There's some other things, like the most common things are carpal tunnel. You have arthritis at the base of the thumb. There's some fractures. There are a lot of injuries. I do still take call at the hospital for hand call. And so, I deal with that sort of thing. There's a lot of lumps and bumps in the hand, ganglion cysts, tumors. There's a lot of different things, nerve problems, other nerve problems you can have. So there's a lot of different things that you can do. There's also some, congenital hand things that come up that you can fix, like if you have syndactyly where the fingers are fused together, or if you have an extra digit, that's more common than you think. Sometimes babies are born with a little nubbin off the side of the little finger, and that's something that needs to be taken care of too.
So I'll tell you an interesting little aside. 2 of my children have syndactyly of their toes.
Yeah.
And then I had another relative who had syndactyly, and they determined that it's related to long QT. that if you have syndactyly, you're more apt to have long QT.
No, I actually didn't know that. Syndactyly does run in families, but I didn't know the connection to long QT.
Which was fascinating.
I didn't know that either, actually.
So did they fix the toes?
No, in fact, there are, and I forget which two toes they are, but they're webbed up to a point.
Yeah.
And my friends would say it's not fair they were on the swim team. It's not fair that they
Yeah,
swim.
that's the running joke. But yeah, usually toes you don't have to fix because hardly anybody, really notices it. But fingers, it's important to fix.
And then the extra digit too.
Yeah, that's usually minor. Most people get a little nubbin off the little finger that runs in families. But you can have an extra thumb. You can have thumb duplication as well. And, again, it's not that common, but you can have that, yeah.
Wow.
Yeah, there's a lot of odd things that you see as a plastic surgeon that perhaps is not known to the general public.
Let's go with the top 5.
Top 5 things. There's a lot of odd things that we see. So, not odd, but unusual things. So, you'll see some gender affirmation surgery. That's become more common recently that, most people don't really think about as being part of plastic surgery.
Can you talk about that more? What do you mean?
Yeah, so I think over the last 10, 15 years, people are more aware that there are pathways you can take if you're uncomfortable with your gender that you're born into. And let's say, wherever you want to stop. So, gender affirmation surgery has been going on for many years. But it was kind of a niche and a quiet part of healthcare that if you really had a problem, you would seek out. Now it's more common. It's probably more common in social media. People are more aware of it. There are more conferences about it. So patients have better access to the information and they're seeking it out, because they just don't feel comfortable with where they are. And so there are more pathways for them to hopefully find happiness in affirming wherever they feel with their gender.
Are these teenagers or adults?
It depends. Some of them are teenagers. There's certain things you can do with teenagers and some things you can do with adults. It depends on, first it starts with a pediatrician, then they usually see an endocrinologist and they usually see a psychiatrist along the way. And if everybody agrees, then sometimes they'll be put on hormones or other things. And, typically the first surgery that people have is called top surgery. So it's the chest. So, if you're perhaps, feel more male and you're uncomfortable with your breasts, you can have those removed and have a more male-looking chest made. But obviously, I'm not the one who decides whether they should have the surgery. Typically, they have already undergone evaluation by a pediatrician, psychiatrist, et cetera. And it's just an affirmation of what those other doctors have already determined to be the correct path.
So by the time they come to you, it's sort of vented out.
Yeah, yeah. I'm not the one who's going to be like, hey, you've never seen anybody, but this is what we should do. That's not really my role in the situation. I have a relatively minor and more technical role.
More mechanical,
Yeah.
technical, yeah.
So, and you've done both surgeries?
Yeah, that's pretty straightforward. Doing both surgeries is fairly straightforward. The other things that people do that are straightforward, you can do rhinoplasty. So a lot of times if you're transitioning from male to female, you don't want a big male nose. So you can do rhinoplasty. There's also people do shaving of the Adam's apple to soften that look.
Wow.
Oh, they do that?
Yeah, those are the more common things that people do. Now, the bottom surgery is usually done at specialty centers. There's a couple in New York.
So you have not done the bottom surgeries?
No, I don't usually do that because that you need to do more frequently. And there's a lot more involved in it, and you need a larger team of people to have it go successfully.
So do you know if you go from female to male versus male to female, which operation takes longer?
I actually don't know. I think the female to male probably takes longer, but there's individual variation.
Right.
Yeah.
So what are some other unusual things?
So some unusual basic things. People come to me and they regret having certain tattoos. Like I've had a few women over the years who have tattoo on the lower back, and they will have changed partners.
Oh, God.
And I don't ask them exactly what was said, but it's clear that the partner did not like the original tattoo that was put on. And usually what they do is they'll have it lasered a few times. But if it's a dark tattoo that's been well done, then the pigment is so deep that the laser doesn't take enough of it away. And they'll come and I'll just remove it surgically in 1 or 2 stages. Even if it's a big tattoo, you can eventually cut it out, and you just end up with a scar that looks like you had back surgery.
Do you put a graft on it, or you
no,
just bring it together?
You just put it together. You do it in stages if it's large. So you take out as big a piece as you can, and then you close it, and the skin relaxes over time, and then you can come back and do it again.
Like 6 months later, or
no, like 6 weeks later.
6 weeks later.
Yeah. Yeah, it's not a hugely long process, and it's not super expensive either. It's done in the office mostly. So,
During your entire practice, have you ever seen conjoined twins?
I have not, no. But plastic surgeons have always been involved in separation of conjoint twins, but that's, again, a very specialized thing in very specialized centers. Yeah.
And then what percentage of your practice is plastic surgery?
Well, all of it's really plastic surgery. Even hand surgery is part of plastic surgery. And, many people don't realize that hand surgery has been part of plastic surgery for many years, 50, 60 years.
Right. I guess that's people opt to have it as opposed to, I guess everybody opts to have whatever the surgery is, but there's certain surgeries that for
elective cosmetic.
Right. Cosmetic type surgeries.
Right. So cosmetic surgeries, it's still very popular. Again, it's partially social media driven, et cetera. The cosmetic procedures that are sort of have been popularized in the last few years is a lot of fat grafting. So we can take fat from one part of the body to another part of the body to change the way people look and change certain areas of their body. So, a typical procedure would be taking fat from the abdomen and putting it in the buttocks to both give you a better waistline in the abdomen and more prominence in the buttocks. And that we see typically, let's say, you have a female who's had a couple of kids, has a little extra skin on the abdomen, and they want that improved, and they want some more augmentation of the buttocks. People also do buttock augmentation with implants. I personally don't do that. I tend to do more fat.
And do you suck that out or cut that out?
You suction that out. Yeah, it's just
Really?
liposuction first. And then usually, with the abdomen, if you have to cut out skin, you can cut out skin after you do the liposuction. But then you do liposuction, you get the fat, you separate it from the liquid portion, and you inject the fat back in the buttocks. You do have to be careful with that. There are many people who are popular on social media who do fat grafting to the buttocks, particularly in like Miami and stuff, who are, let's say, underqualified. And there have been a number of deaths over the years from buttock augmentation. So originally when people did buttock augmentation, they did not pay as much attention to the plane in which they put the fat. Meaning, is it just under the skin? Is it in the fat, under the skin, or is it in the gluteus muscle? So people used to think, fat survival is probably better in the gluteus muscle. Let me put it in the gluteus muscle. The problem is that there's a large artery and vein that go through the gluteus muscle. And the fat, after a certain amount you put in, gets a lot of pressure. And the fat would find its way into the gluteal vein and then into the lungs. Wow. And those people would die. And there was a significant number of deaths from fat grafting to the buttocks. And so really what has been determined is that you shouldn't really put it into the muscle. You should really put it into the subcutaneous fat plane. And if you don't pay attention to that, then you run into problems.
So out of the cosmetic surgeries, what percentage is the face? What percentage is perhaps the chest? What percentage is?
I mean, it's pretty even. It really depends on, I think it depends on the age of the patient. So if you have a patient, and the majority of patients are female, but there are more males having all of this done. So let's just take a female, for example. So when female patients are young, if they have small breasts, sometimes they'll want breast augmentation. That might be in their 20s. If not, let's say they have children and they have some extra skin on the abdomen, they may come to have some body contouring, have the abdominal skin removed, have the abdominal wall muscles tightened, maybe have the breasts lifted after they've had children. So, and then when women get into the late 40s, early 50s, they get extra skin. Actually, everybody gets extra skin in their upper eyelids. And then they might want the extra skin removed from the upper lids, or you get a little bulging of fat in the lower lids, and you might want to have the lower lids looked at. Typically now people are doing Botox and fillers in that age group as well as an adjunct. And when you get into the 50s and 60s, then people want their facelift or their neck lift. And then we're also doing fat grafting during a facelift. So that's one of the things that's also developed over the last 10, 15 years is people, we used to think of facial aging as skin sagging only. So we were always like, oh, let's tighten the skin. So, but then we've come to realize as a profession that we also lose soft tissue in the face, especially, with people working out and trying to stay thinner. And now people are on weight loss medication. We realize that people lose a lot of soft tissue in the face. And restoring that soft tissue by putting fat in the face actually improves the appearance of everybody's face. It's pretty dramatic how much it improves it. It's not intuitive. Like even when I started doing it, I was amazed and shocked at how much better people look just with fat grafting, even without tightening the skin.
Where do you get the fat from?
Usually on the abdomen or thighs, depends on where people have it. Even thin women will have some fat that you can extract from the thighs.
And then you inject it into the face?
Yeah, you inject it into the face.
And it just stays there?
Yeah, they actually came out with a study. So it was actually, well, it wasn't on the face, but it was on the buttock. It showed that about 50% of the fat stays at 8 months. So, usually you overfill it a little bit. And you can do, typical areas would be the cheeks, the nasolabial fold, which is that fold that is right on the side of the nose that people develop. You can do the lips if people want some lip augmentation. You can do the temples if they have a wasting of the temples, some loss of soft tissue in the temples. You can do it in the hands. Hands work really well. You take some fat, as people age, we lose soft tissue in the hands. There's more bony prominences. The veins get a little more noticeable. The tendons are more noticeable. And sometimes if you're there anyway, doing something else, you can just put some fat in the hands, and that looks spectacular, actually.
So if people come into you, is there ever a time where you say to them, no, I won't do that?
Yes. If people are asking for things that are dangerous or they want too many procedures at once, then we have to talk about it. Or something that's, completely outrageous. Like I had one patient once come in, and this was many years ago, and he was on blood thinners, and he was diabetic, and he had a lot of medical issues, and he wanted something done. I'm like, yeah, it's not really the safest thing for you to have this done. And I said, you should probably not have this done,
But if a female came in and said, pick some huge breast size, if I want breasts that are this big, you would do it?
It depends on the patient. So some patients, so I can tell you, I'll give you an anecdote. So I had a patient once who came in and wanted much larger than average breast implants. And I was a little concerned, but she had actually researched this, and she was probably the most well-informed patient I've ever had for breast augmentation. I didn't ask what the purpose was. I mean, you can sort of read between the lines with that purpose. But and her skin envelope could handle it. That's the most important thing, right? If you have somebody who has very tight skin on the breast and they want very large implants, that's not safe because the skin's not going to be stretchable enough to do that. So you're going to run into a lot of complications. But this person had an adequate skin envelope. So I was like, okay, if this is the size you want, we can do it. You're going to look, I sort of demonstrated how she was going to look. And I'm like, are you okay with this look? Is it socially awkward for you to walk around with this look? And she's like, no, this is what I want. And she was otherwise pretty reasonable. So I did it. She had a great result and she was very happy. And that wasn't the problem. So it's more about like vetting the individual patient than, oh, I want this outrageous thing done. So each patient that encounter that you have to sort of, I have to sort of get an understanding of the patient motivation, their level of understanding of the procedure. Obviously, you have to talk about risks and so forth. But you really have to make sure that they understand what they're getting into and then they have the right goals in mind for what they want for the procedure, the right motivations. Sometimes that comes into play with smoking. So let's say somebody comes in and they want a breast reduction and they're smoking. So smoking has very negative effects on plastic surgery. And that's been well borne out. So ideally, people would stop smoking before having, let's say, a breast reduction. So if a patient cannot commit to stopping smoking for at least 6 weeks before breast reduction surgery, then maybe they're not committed enough to undergo that surgery. If they look around, they'll find somebody who's willing to do the surgery for them because there's always somebody who's willing to do it. But in an ideal world, they would stop smoking and then have the surgery because it's just safer for them.
And is that a circulation issue?
It's a circulation issue, yeah. So in plastic surgery, we are moving tissues around the body, and we are moving tissues based on their blood supply. Because if you take a piece of tissue off the body, it's basically dead, right? So, most people have heard of skin grafting. Skin graft, you take some skin off the body and you put it somewhere else on the body. So once you remove it from the body, it's basically dead. If you left it out, it would just shrivel up and die. But you put it back on and it reattaches eventually. But when we move tissues, we have to make sure that tissue can stay alive. So in a breast reduction, most people who undergo breast reduction, their nipples are at a low point on their body, and they would like the nipples to be higher. So we have to move that nipple, areolar complex, on some breast tissue to keep it alive. And if you don't have enough blood supply to that nipple areolar complex, then even if you move it, it's going to die. And that's a big issue because then you lose it. You have to reconstruct another nipple areolar complex. Never looks quite as good. It's more surgery. Most people are dissatisfied if that were to happen.
And can you tell pre-surgery whether or not it's a healthy area to do this?
No, it's not about that. It's about sort of the patient's anatomy and smoking. So in smokers, you're going to have problems healing that typically because it does affect the circulation. But also, it depends on how far you're moving the nipple. So sometimes you get women who have very large pendulous breasts where you're moving the nipple 10, 20 centimeters, let's say. Mm-hmm. And that, once you get into the 20 centimeter area, that's a long way to move the nipple. So the longer way you have to move it, the more problems you could potentially have.
So this might be your superpower, can you look at a woman and tell whether or not they've had breast augmentation?
No, not always. Sometimes you can tell, but 95%? Not always. 95%? It's not like, I haven't tested myself. I don't work at a carnival doing this, so I don't know. But often, it's basically the woman's frame versus breast size. So you can tell when a woman has a generally thin frame and has breasts that are probably proportionately larger than the frame would probably indicate. That's not always accurate. You think back to the old Seinfeld episode, right? You remember that one? And so, you can't always tell, but sometimes you can tell, yeah.
So we were talking earlier, you also do volunteer work.
Yes.
So why don't you talk about that?
So, volunteer work has been a staple of plastic surgery overall for years, and some people do it and some people don't do it. Most people do some in their residency. So I've been fortunate enough to be with a group from Yale, from one of the people that I trained with, and we've gone to Central and South America over the last 20 years doing primarily hand surgery, primarily congenital hand surgery. So congenital hand means, children that are born with hand deformities. And it's more common than you would think. Most people haven't come across somebody with a congenital hand deformity in their daily life, but there are plenty of patients out there, especially who are undertreated in these parts of the world. So, we take a team down to one of the countries, and we use their operating rooms, and then we try to fix whatever we can. And then some of it's trauma, but a lot of it is congenital hand. So the most common places we've gone to the last few years have been Peru, but we've been to Honduras and Nicaragua in the past. It's really great. It's a great experience. Operating on kids is great from the standpoint that they heal everything. So it's not as much of an issue. They don't have many medical issues usually. They don't have as much pain as adults for as long. So after a couple of days, they're happy and they're on their way. And obviously the parents are very grateful. We don't charge them anything, but as we say, they don't pay us anything, but we make it up in volume. So.
So you'll go down for a trip like that, and how do they determine who's going to be the candidate?
So usually what happens is we have a local doctor that's our contact, and they have mechanisms to advertise. So usually it's print advertising, and we advertise that we're coming down there for this problem, and if you know somebody, then tell them to show up at the clinic. And, fortunately, most of these countries have some sort of socialized medicine, even though it doesn't work great. And so they can all come and get registered. And some of the patients come from far away. I mean, in Peru, we usually operate in Lima, and a lot of the patients come from like way north or from the Amazon, and they have to travel a couple of days by bus to get there. So, we try to operate on everybody, if they're a candidate, to do it safely and in a manner where they can get the best result possible.
So do you have like pictures of these people before you see them, or you just see them for the first time?
No, we've been doing it for a long time, so we can figure it out there. Occasionally, one of the local docs will send us some information. Hey, can you do anything for this patient? And once in a while, there are patients that you can't do anything on. We've had a couple of kids over the years who actually had congenital heart problems, and they're not really candidates for surgery because they're too sick. And so, we couldn't do anything for them.
How many surgeries in a day would you do on average?
5 typically, and we do 5 a day for usually 5 days. It depends on
you must
the
be
patient.
Exhausted at the end of those 5 days.
Yeah, but it is taxing. But as a surgeon, it's what I do, so it's not as taxing as, let's say, if you were to make me play football for 5 days in a row or something, because being in the operating room becomes second nature. Just like a lawyer being in the courtroom would be second nature if you do that all the time, although it may be intimidating to the layperson. So, it's not as taxing for the surgeons. I think it's more taxing on the staff that come with us because they have to learn a whole new system where things are. The surgeons are still asking for everything like they always do, and they have to, the staff has to find stuff to do. So,
especially with the language difference.
Yeah. I mean, unfortunately, I picked up enough Spanish that my hospital Spanish is pretty decent now. So, it's not as much of a burden for me. But other people, we have to get local translators and stuff.
You can say scalpel, retractor, all the things in Spanish.
Yeah, all the important things.
We wanted to take a quick break to remind you about our sponsor, FindAGreatAttorney.com. Dealing with the aftermath of an accident or injury can be overwhelming. And the last thing you want to worry about is finding the right lawyer. FindAGreatAttorney.com simplifies the process by connecting you with one of the top attorneys in your area who specializes in your specific type of case. Whether you've been injured in a car accident, suffered a slip and fall, or experienced medical malpractice, FindAGreatAttorney.com has a network of experienced lawyers ready to help. And remember, their service is completely free, so you can focus on your recovery without worrying about the cost of legal representation. If you or someone you know needs legal assistance, don't hesitate to visit FindAGreatAttorney.com and let them match you with one of the best lawyers in your area for your needs.
So as genetic testing becomes more and more, you're probably seeing more people with positive BRCA, and they're asking for prophylactic bilateral mastectomy.
Yeah.
And then you fix the breast afterward. You want to talk about that whole process?
Yeah, so it's a difficult decision for patients and their families to make. But you have to look at it the other way. Like, thank God we have the screening to allow you to have that decision to make, so that what's going on and you can make that decision. I mean, I personally, obviously I'm in the field, so I am a proponent of just doing the bilateral mastectomy and reconstruction because ironically, bilateral reconstructions almost always look better. And the reason for that is you're doing the same thing to both breasts and you can make them look symmetric. It's actually harder to do a unilateral reconstruction because then you almost always have to do the other side to try to match it better.
So what are we talking about for lay people? What's the study that shows what and why would they elect to do this?
We have determined that there are certain genetic traits that some patients have, females, which make them more likely to develop breast cancer, and perhaps in both breasts. And there's some other associated cancers that can happen with it. But now that we have that genetic testing, more patients, let's say, woman finds out that her aunt has breast cancer. The aunt got genetic tested and has this gene. She might go and get tested for this gene and say, oh my God, I have this gene. I am at a higher risk for breast cancer. It's a significant risk. Mm-hmm. And then she says, well, what should I do? Should I have a prophylactic mastectomy, which basically reduces your risk to zero? Or should I just watch it and have more screenings? And so that's the dilemma that many women sort of come up against. And then they have to decide, well, I'm going to have the prophylactic mastectomy, which is, a big process to go through, the reconstruction, et cetera. But then your future risk of breast cancer is zero and you don't have to worry about it. You have scars on your chest and your breasts are not exactly how you were born with. So it's a difficult decision. But I think, as I said before, I am a big proponent of it because I think if you do a bilateral reconstruction, you should be able to get it to look pretty good. And like I said, you can make it symmetrical because you're doing the same thing to both sides, whether you're putting the same size implant in or whether you're using the patient's own tissue, whatever you're doing. It's generally looks pretty good once you get through the whole process.
So when you normally do a breast augmentation, is it under the skin or under the muscle?
So, typically, it's under the muscle. You can put it on top of the muscle also. Most cosmetic augmentations are done under the muscle because they hold up longer. Literally, they hold up so they don't drop as much. And it's also less, it's more natural looking and you can feel it less because the muscle is there hiding the implant.
So when you have the bilateral, that is you're taking both of them off.
Yeah.
Does that then go underneath the muscle?
So in years past, it was primarily under the muscle. The trend in recent years, they've been trying to do it on top of the muscle more. I think it's a little bit easier on the patients. And I don't know if that trend's going to continue long term or if it's going to go back to under the muscle. I don't want to get too technical, but we have to go back and see what the complication rates are when you put it on top of the muscle versus under the muscle. And then practice patterns may change in the future based on that.
And when you do the bilateral removal, you're leaving all the skin there, but you're taking out what is inside the breast?
Yes, exactly. So most of these patients, they're having what's called a skin-sparing mastectomy, meaning that they leave most of the breast skin, or if you have a very large breast, what they'll do is they'll do a pattern like you would have a breast reduction. So they take some skin out, and then they remove the breast tissue, but they leave enough skin that you can put in implants and you have enough skin. Otherwise, let's say you do a traditional mastectomy. In a traditional mastectomy, they take a lot of skin and the skin is tight and you can't put in an implant. And what you have to put in is what's called an expander, which is basically a flat implant that you then put saline in to stretch the skin out over time. And then once the skin is stretched out and you have an adequate pocket, then you can put in a bigger implant.
Interesting.
Now, the implants you're doing now, I guess they used to be silicone. Are they back up now or what's?
So you may or may not remember, years ago, there were silicone implants that were made by Dow Corning, and there were some issues with them. So what had happened is when they leaked, they looked terrible. And there were lots of pictures floated about how terrible they looked. And some women were attributing some of their health issues to this leakage of silicone. And so the FDA took it off the market. Interestingly, they were never taken off the market in Europe. And and they kept them there, and there was no litigation in Europe, interestingly. But anyway, so then they were off the market for a while, and then they were reintroduced with a slightly different configuration, so they didn't leak like they used to in America. And now I think those are being used much more frequently.
So they don't use the water-based. Wasn't there a water-based?
Yeah, you can still have saline implants. People still do saline implants, and that's a perfectly good option. It doesn't feel quite as natural as the silicone because of the makeup of the silicone. The new silicone implants are made like, they call it a cohesive gel, but it's basically like Jell-O if you looked at it. So if you imagine, if you cut Jell-O, it keeps its shape. It doesn't leak all over. So the new implants, it's like that. So if they get a hole, the implant material is not leaking all over the place like it used to.
So why would you choose saline versus silicone? Or?
So that's a discussion that's very personal to patients, and obviously they decide that based on discussion with their doctor. The silicone just feels a little bit more like breast tissue when it's inside the body, and that's the primary driving factor in patients. The saline and the silicone look pretty much the same when you look at them without touching the breast, but when you feel the breast, the silicone is a little more natural. So people are sometimes drawn to that a little bit more.
So what is your typical week like? Do you have days where you're in your office consulting and then days that you're in surgery? And how does that work?
Yeah, so typically most surgeons have 1 or 2 surgical days in the operating room. So I have 2, that's Thursday and Friday. The rest of the week, I'm seeing patients in the office, either in consultation or I'll do a lot of small procedures in the office. So there'll be procedures like, let's say I take skin cancers off, or lumps or bumps, or sometimes I'll do Botox and fillers in the office. So that's the type of thing in a normal day, I would do some variety of those things.
And is Botox, once you get it, you have to keep getting it?
You don't have to. So Botox, the biggest problem with Botox for patients is once you get it, you're going to want to get it again because it really works well. And so then you have to budget for it. So you don't have to get it again. If you do Botox once and you never do it again, you just go back to the way you looked before you did Botox. It's not, there's no permanent, changes.
Kind of defeats the purpose of having it once.
Yeah.
Right. But I mean, like sometimes I'll have patients come in and say, oh, I've never tried it. I just want to try it. I'm like, that's fine. Try it. And if you don't like it, don't have it again. It lasts about 3 months. And then I have other patients who, for a variety of reasons, only come for like birthdays and weddings. And that's fine too. So, you can pick and choose what you want based on your motivations and financial considerations, et cetera.
So where do you put the Botox, and what do you?
So Botox is typically used in the upper face mostly. So it's used in the forehead to reduce forehead lines and to raise the brow. So it does take care of wrinkles, but it also raises the brow, which makes a huge difference in everybody, men and women, but particularly women, because women's brows, the ideal brow position is much higher than men's. So it gives them that arch that they're looking for, gives them a higher brow position, opens up their eyes, especially women in their 40s and 50s. So the other places you can use it for the crow's feet, which are the wrinkles around the outside of your eyes on the cheek. They're more pronounced when you smile. You can use it for that. Some people have wrinkles on their side of their nose. You can use it for that. If you have chin dimpling, you can use it for that. You can use it for muscle lines on the neck, the so-called platysmal banding. That's what that's called. You can even use it for people who grind their teeth from their masseter muscles being tight. So that's a muscle on the side of the cheek. And some people like it because it narrows their face. So if you have somebody with a full face who also grinds their teeth, you can inject it in the masseter, and over time, the masseter will atrophy and it will actually look better.
And what is Botox?
Botox is it's a material, it's a protein that blocks nerve transmission. So when you want to activate a muscle, let's say you want to activate your bicep, you have to send a signal from your brain to your bicep, hey, bend my elbow, right? So what that does is it blocks that pathway from your brain to your muscle, but it blocks it at the muscle level, not at the brain level, obviously. So when you inject it into the forehead, it blocks the muscles that help you frown.
Wow. And that's got a life of approximately 3 months?
Yeah.
So if somebody percentage-wise, what percentage are male, what percentage are female?
Well, it's probably 80-20 female male.
And then if you want to have this done, how many places can you have it done when you come in for one visit? It's
generally a low dose, so you can have a lot of Botox done. It's really generally just limited by patient motivation and financial issues. It's not really motivated by the dosing, because the amounts that we use, some people come and they're like, oh, I heard this is a toxin, I don't want to use much of it. But the doses that we use are so much less than you would get if you were toxic, or if you had botulism, that it's not really a concern. So you can use, the most I use, it's sold by units. So let's say in the forehead, you might use 20, 24, 30 units. crow's feet, another 10 units, but you can use more if patients need it. I mean, the most, I've done in the office on a patient would be like 160 units, which sounds like a lot, but it's really not in the greater scheme of things.
And you charge by the unit?
Depends. Some places charge by the unit. I think that's what most places charge by, because it makes the most sense. But some people charge it by syringe, etc.
So what's like if you have the average person come in for the average amount of Botox, what does that cost per?
Probably, the prices are anywhere between like $17 and $20 a unit. Maybe you can get it for $15. I mean, some people go on Groupon and get it for like $12 a unit, but I think that's probably watered down. That's my personal feeling on it, because I've had those patients come back and they're like, oh yeah, last time I used my Botox, it only lasted a month. So, I'm guessing that people water it down for that.
People go on Groupon for Botox?
Yes, can you believe that? Yes.
What about headaches? Do you do Botox for headaches?
I do not personally do Botox for headaches. The Botox for headaches thing is different because the neurologist has to work up where the headache's from. Sometimes it's from the back of the head, sometimes from the front of the head, and they generally do the Botox for the headaches. So it's not something I've done. I've done Botox for like spastic disorders in the face and some spastic disorders in the hand, because it really does work well for that.
So what are some great success stories that you've had with surgery?
So some of the best ones, I'll go over a few. So when we go on these trips to South America, there are some children that are born without thumbs, or born with thumbs that are completely useless. They're like little nubbins. And so we can make them a thumb out of the index finger. So they have 4 fingers, but no thumb. So you take the index finger and you make a thumb out of it. And it's life-changing because they can then go on to a fairly normal life with an opposable thumb.
So you have like half an index finger and the other half is your thumb?
No, you take the whole index finger and you make a thumb out of it.
Can you explain what opposing the thumb means?
Yeah, so the thumb is humans have an opposable thumb, meaning you can take your index finger and your thumb and you can pinch with it. So that's the thing that allows us to hold a pen, do so many things. And if you don't have a thumb, it becomes very hard to do those things. So it's better to sacrifice an index finger and make a thumb, because your function over the life will be much better. And it's really a fascinating operation because so you can't do it in adults, because our brains don't have the pliability to accommodate the index finger becoming a thumb. But children, they can accommodate it, and they just start using it like a thumb, and they do great. And that's the amazing part of the operation. I mean, it's technically interesting, which intellectually is great for me, but it's really the outcomes that's really great.
And an adult will not be able to manipulate their index finger when it's their thumb?
No, the index finger's gone.
Right.
So they won't care about the index finger.
No, but I
being
mean
gone.
their thumb now, which was their index finger, they can't move that as an
They
adult?
can move it. Well, no, they can move it as an adult. But I'm saying if an adult loses their thumb, you don't make them a thumb out of the index finger because their brain won't accommodate it.
Interesting.
Yeah. Yeah. So those are like great operations.
The opposing thumb makes us human.
Yeah.
And actually the primates started with that, so they could pick up things, and it turns us into things that nobody else.
And as you're saying that, I'm thinking to myself, if you don't have a thumb, there's so many things that you can't do.
The thumb is about 50% of your hand function. So.
And then the other thing I heard is if you don't have your large toe on your foot, you have balance problems.
You can. I mean, so sometimes in adults, if they lose, let's say an adult has an injury and they lose 4 fingers and they have 1 finger left. So you can actually take a toe and make them a finger. So you can take a toe, usually it could be the big toe, could be the second toe, and you can bring it up to the hand and you can give them a second finger so they can pinch with 2 fingers.
Wow.
Wow, that's amazing.
Yeah, that's pretty cool to do.
Wow.
What other great stories do you have?
You can actually do some interesting replants. When I was a fellow at Yale, we had a person who we had to replant their penis back on. So, yeah, it was usually these cases are psychiatric cases or terrible accidents. And, they come with a part, and it's actually not that hard to do, surprisingly. It's the only one I've ever done in my career. Nobody specializes in that. And it actually functions pretty well, at least for urination. But that was an interesting case that you don't see very often at all.
How much inside stuff do you have to stitch versus the outside?
It's more about the arteries and the nerves and the veins. So the inside stuff you don't have to do a lot of. Usually we do it with the urologist and they do the inside stuff. But the arteries and the nerves are the important thing. So, and the veins, because that's what, first thing, whenever a body part is cut off, you have to bring blood supply back to it. And so you have to put the artery back on. And once you have blood supply, you have to have a way for the blood to circulate back to the body. So you have to put the vein back on. And then if you don't feel a body part, you don't use it because you don't get any feedback from it. So you have to try to fix the nerve so that you get some feeling back in whatever body part you're putting back on. It's the same for fingers and toes. And
so do you know, is that person able to have an erection?
I do not know because I wasn't there long enough to follow up to that degree.
So you've probably done more penile attachment surgeries than 99% of the doctors in the world.
Yes, if that's a competition, yes, I've done all of one.
So that's a specialty.
Yeah, that's an interesting case.
Wow.
Yeah, and then there's some other things. You do a lot of finger replants when you're in training. I did a whole hand replant once.
What? It's like lost in an accident, and they bring it in a bag. And then
it was a baker who had. He was working in a bakery at like 4 a.m. and somehow he got knocked out or passed out and his hand fell in the machine. And the whole hand was removed, unfortunately. And he came in and, it took about 10 hours, but we put it back on. Unfortunately, he was in his 50s, which has some challenges. Generally younger people do better with replants. The middle-aged people. So he was, was very stiff. The nerves didn't come back great, but it was attached and it survived.
So if it's reattached, is your brain going to know that this is your index finger, or does that get all screwed up?
No, that's usually okay because you put the nerves back together, and the nerves can recover. And usually it's not the brain that's a problem. Usually it's stiffness.
Oh.
Yeah, usually people get very stiff, and the nerves don't recover 100%. So in adults, when you cut a nerve and you put it back together, it doesn't recover 100% usually. So it's hard to get the same level of feeling and feedback post-injury as you had before injury. And
do you also do amputations?
I can. I have done them if they're necessary.
And then the interesting thing I heard is the phantom pain. Like if you have, the bottom of your leg, below your knee cut off, you'll have pain. You think you're experiencing pain in your lower leg.
Yeah, some people have that as a residual from these injuries. There's a lot of, I think one of the things that's underreported is how much mental strain there is after these types of injuries.
Oh.
And, you could really see it in some patients. Some patients, they don't talk about it, but I think it's something that's been underreported generally, that there is a lot of mental strain. I don't know if you want to call it PTSD. I'm not a psychiatrist, but I think it's underreported. I think a lot more of those patients would benefit from seeing somebody about that, because it'll be something stupid. They're like, oh, I can't believe I, put my hand in the table saw. I'm so stupid. I've been doing it for 20 years. And they'll keep replaying that incident in their head instead of moving on and coping with it better. And I think, sometimes it's good to have those patients see a mental health professional about it.
We had a neighbor who did that with a table saw and cut off a number of fingers. And
yeah.
You're constantly reminded of the fact that if I had only been more careful.
Yeah, and there's a lot of regret because these are not people who just started using power tools. It's usually not the first 10 times you use it, it's like the 100th time and you're rushing.
Sure.
And, you have your mind on something else or who knows. And it's just an accident. It's a split second and that you could have done better and had safety measures and so forth. And it just eats at you, I think, a little bit.
What's the best part of your job?
My best part of my job is coming to work and seeing what I'm going to see. Every day is different. I think that's one of the things that appeals to me is that I enjoy working all over the body, doing different things every day. Every case is intellectually different, and I think that's the part that I still enjoy the most. The outcomes are great. Like you as a surgeon, you always want to get the best outcome. At least you should always want the best outcome, right? So that's sort of an expectation that you have to begin with. That's not something that I would change per patient. Like every patient I want to get as best as I can, right? So that's a given. But the intellectual journey to get there is the interesting part.
Interesting.
You know, so you have a patient.
More than the technical, you like the intellectual.
Yeah, the
part.
technical part, you know, after a number of years of practice, you've gotten the technical part down, or you should have the technical part down. It should not, you know, like, I mean, some people, I guess, never, I shouldn't say never, but they have some technical challenges throughout their career. But if most people are competent, they've been in practice 10 years, they know the technical part, right? Every operation has like 6 important steps. You just got to get those 6 important steps right. So the technical part, you know. It's more about sort of planning and execution and strategy, if you want to call it that. You know, and you see that a lot in, I think you see it more in cosmetic surgery, interestingly enough, because patients will come in and they'll have an idea of what they want, but they don't know exactly what they want. So, you know, you'll see it in patients who come in and they're like, well, you know, I have this extra skin on my face. But then you look at them, they're like, oh, you know, your skin, you know, you've been exposed to a lot of sun. You got a lot of soft tissue loss. You know, they can have like 3 other things. You're like, well, you should probably have these things done as well. You don't have to, but, you know, this is probably the best approach. And so you have to really tailor or customize that operation to the patient. You know, so it's really about customizing the operation to the patient so they get the best result possible. And then some of it's also just innovation. You know, I enjoy new gadgets and things and trying different things and different ways to do it. And I think that's probably true of most plastic surgeons.
So as our time is drawing to a close, what suggestions would you have for somebody who's interested in having plastic surgery done, cosmetic surgery?
So there's a lot of stuff on the internet, you know, you can research it, but you should go to sort of websites from professional organizations, like whether it's the Mayo Clinic, American Board of Plastic Surgery is great because if you have to be board certified, make sure your plastic surgeon is board certified by the American Board of Plastic Surgery. There's a lot of like fake boards out there, really? because people who are not certified by the American Board of Plastic Surgery can go to these other boards and get, let's say, I'll just make one up, American Board of Excellent Cosmetic Surgery, right? So they just get a certificate, but they've never really had the training that you should. And their outcomes will probably reflect that. So obviously, you know, everybody says, oh, do your research on the doctors. Yeah, and everybody says, oh, look at before and afters. But people only put up their best before and afters. Right. You're not going to get people's best average before and afters most of the time.
That's a great point.
So you're better off, you know, one, if they have a good reputation in the community, you know, obviously if you know somebody who's had surgery by them, check out the professional organization to get information about the procedure. Make sure they're part of that professional organization.
Maybe ask your GP.
They're also very good. Yes, they know who's been in the area, or if you know a doctor in the area. Like my friends ask me all the time for referrals for doctors, and you know, I know sort of the nuances of who's better at what, et cetera. And then also, you know, just get a feel for the doctor when you meet them. Like, do they have like a decent personality? You know, it amazes me how many people will have somebody operate on them that they didn't really like. And I mean, you don't have to like your surgeon. Maybe he's a great surgeon and you know, he just has a terrible personality. But in an ideal world, you know, you should be able to find somebody with a decent personality who's also capable that you can connect with, because it's not so much a problem if you don't have any problems, right? The problem becomes if you have a complication, do you have the trust in that doctor to then take care of that complication? You know, and that's really what that connection or personality is about, is that, yes, I had the discussion with the doctor. He explained it to me. I trust him that he's going to do the right thing if I have a complication. And, you know, because afterwards you may not have that trust factor built in.
Also, there's a give and take here because everything is not black and white, right? So you discuss what you want to do.
Yes.
And it's not, like I said, black and white. So it really is important to have that rapport and be comfortable to discuss stuff with your plastic surgeon.
Yeah, I mean, that's especially true like if you do rhinoplasties, you know, because people are very specific about the way they want their nose to look, right? So if you go somewhere and the guy's like, yeah, I always do this nose, or this is how I make everybody's nose look, or this is what you should have done, they're dictating it to you, then, maybe they're not the right doctor. I don't know. But generally, the doctor should at least ask you how you would like your nose to look and why before they put their own sort of stamp on it. And you may come to the same conclusion, but it's better if the patient expresses it and you come to the same conclusion.
So lastly, how can people contact you? What's your website?
I'm part of a group, Advanced Specialty Care. It's ascdocs.com, docs.com. Or you can call the office. It's 203-791-9661. Or you can Google me. I'm sure you can find the office number through Google. So there's different ways to get in touch with me if you're interested.
Dr. Islam, thank you.
Well, thanks for having me.